Cutlip from Boston, Massachusetts. I'm here with Dr. Philip Urban from Geneva, Switzerland, the principal investigator of the Leaders Free trial. Welcome, Philip. And we're going to talk today about the eCOBRA results and a bit about the clinical development from the COBRA PzF nanocoated stent.
Yes, absolutely. Hi, Don. Nice to see you here in Paris. The eCOBRA was presented just 2 days ago by Luc Maillard, who is the PI from France in the south of France. And there are several really interesting and quite impressive aspects to that large registry. It's French, it's prospective, multi-center. They've got very close to 1,000 patients, so that's quite something. And the methodology, I think, has been quite strict. They've had a sort of independent CEC and independent angiographic reviews. It's quite solid in that respect. And yes, I think many of the results are extremely interesting. But perhaps before that, Luc tells us that they feel they've selected patients that are close to the leaders-free population. And certainly looking at the mean age, I think it's in the range of 75, that does fit that bill. We don't have quite enough information to make quite sure how comparable the populations are, but they are defined in a very simple operational way as non-DES candidates. Of course, I guess that could vary from center to center, but yes. They've got good, solid follow-up with excellent numbers. Hardly anyone lost to follow-up out to 1 year. And
they had a high rate of acute coronary syndrome patients as well.
Very important, absolutely. I think it was in the range of 40 or 50% of patients presenting with either non-STEMI or STEMI. You're right, very important to make that point. And one of the numbers that I was impressed of very favorably was the need for repeat revascularization. I mean, that was in the just above 4% at 1 year. And when you think that what we know of the late loss with this device, it's not a drug-eluting stent. Its major feature is its thromboresistance. I think that TLR is really quite spectacularly good. So this is real life in France. There's no problem to recath people if they need it, so they would have had it if they had needed it. So that's the number that, to me, is most encouraging. There are a number of other numbers that are interesting. The stent thrombosis was 1.2 definite and probable at 1 year. It is an important point because you can either be an optimist and say in leaders free it was more than 2%. So if these are roughly the same patients, this is telling us something. If on the other hand you say, yes, but this stent is supposed to be supremely thromboresistant, then is that number still as good as you could have hoped for? I think the investigators are going to have to look into that data in great detail, find the relationship between DAPT duration and the thrombotic events, whether MI, stent thrombosis, and so on, and tease out more information. It's probably there for us to find, but we haven't yet seen it. This is a preliminary analysis.
I mean, I think that's a great point, because since it was a registry, that there was not so much protocol-driven DAPT duration. So I think investigators were doing different things. Some got single antiplatelet therapy. Sometimes it was only 2 or 3 weeks, and whether that has any impact on stent thrombosis, I think will be important to sort out.
Sorry.
We'd
like to know that.
Yeah.
Absolutely. And I think we shall. I think Luc was quite positive that he could eventually get that information. They've only just finished having a first look at this data set, and so we will eventually have that information.
I think, it was important for them, obviously, to present the results here. He just has seen the data, so I think we're both confident that he'll go back and the investigators will go back and look at these other questions.
Absolutely. I guess if we're looking at some of the limitations of the registry, another element that I believe may not be fully available is the amount of bleeding that will have been. And you could argue that so what? They've probably done as short as DAP as they possibly could, and that was because of their concern about bleeding, but it would have been nice to have some numbers on the bleeding. And again, I believe that both the investigators and the sponsors are hopefully going to look into what information they can find regarding that. I think it would be a nice balance to have the thrombotic complications and at least some of the major bleeding complications.
I agree. So CeloNova is running another important study, COBRA Reduce, international randomized trial Can you tell us a little bit more about that study, especially your impression of the design and what we may hope to learn from those results?
It's a very impressive, very ambitious design, and it's potentially game-changing because they're going for 1,000 patients on oral anticoagulants. And the idea is the patients will be randomized to either a drug-eluting stent and the standard guideline-driven 3 to 6 months, from what I understand, currently, DAPT, or the COBRA Polyzene stent with only 2 weeks of dual antiplatelet therapy, which is extremely aggressively low. And so there will be 2 endpoints. The main primary endpoint is to see whether bleeding can be decreased in terms of superiority, which I would think can be pretty obviously reached. And then they obviously have to balance that with a non-inferiority in terms of thrombotic complications. And this is ongoing, and I understand it's in excess of 400 patients. And recruitment was slow to begin with, and it's picking up. So certainly we hope that this trial will shed some more light. It could be a very important addition to our options in these patients.
So maybe I'll just comment on the role of the COBRA PzF in practice. Do we have enough clinical data at this point where we can advise clinicians, put this on the shelf and use it during X, Y, and Z, or do you think we just need more information?
I would say for today, from what I understand, and correct me if I misunderstood something, but I believe the device is available in the US with a 1-month label.
Right.
So if I was a US physician, I think this would be a very good choice for the patient who needs urgent major surgery, who really had a recent nasty bleed. The sort of leaders-free patient now in the US, I would be quite happy to go with this stent in 1 month. In Europe, if I can have the biofreedom for the moment, I prefer the biofreedom because I have more data. But this may very well be a perfectly viable alternative, or perhaps even better, because 2 weeks is shorter than 1 month. And that's something to think about.
Yeah, I think there's 2 interesting points or parts of this. And one is the antithrombotic opportunity with shorter DAPT, and I think we need more information on that. Alok Finn was here before you and talking about some of the preclinical healing data in terms of endothelial function and maybe as a prevention for new atherosclerosis. Obviously, we need a lot more evidence for that, but it might be another place the stent would come into play in those patients who are not at high risk for restenosis, perhaps.
I was actually impressed by Alok's data, and he's probably discussed it much more seriously than I can possibly do. But in his ex vivo shunt model, where he puts in a sequential order of different stents, you see platelets that adhere in large numbers both to polymer-coated drug-eluting stents and to bare metal stents, but not to the COBRA. And so, to me, despite the relatively high late loss, this device does seem to have antithrombotic properties which are unique. At least in Alok's model, it's very clear. And that's why I think this device may have a big future, but it's a little early to say.
Very good. Okay, well, it was very nice talking to you about the device, and thanks for stopping by.
My pleasure.
Yeah,
Thank
good
you,
to see
Doug.
you. Yeah,
Thank
take
you.
care, Phil.